Hello, my name is Dr. Don Buford, and I'm an orthopedic surgeon in Dallas, Texas. I'm the founder and director of Texas Orthobiologics, which is a clinical center where we combine orthopedic surgery with orthobiologics. Today we're going to discuss our recently completed study on bone marrow concentrate injections for partial thickness rotator cuff tears, 2-year results. I'd like to cover the natural history of rotator cuff partial tears. We'll review some of the non-surgical and surgical options for rotator cuff partial tears. We'll go over our unique study design. We'll go over our ultrasound-guided posterior iliac crest bone marrow aspiration technique, as well as our ultrasound-guided rotator cuff injection technique. And we'll review the cellular analysis of our bone marrow concentrate and the clinical results from our 2-year study. I'd like to first try and define the prevalence of partial thickness rotator cuff tears. There was a study published in the Journal of Bone and Joint Surgery in 1995 that looked at asymptomatic patients with MRI scan. What they found was in 96 asymptomatic patients, 20% had partial thickness rotator cuff tears. If you stratify the patient population to those above 60 years old, 26% had asymptomatic partial thickness rotator cuff tears. Another commonly asked clinical question is, do partial thickness rotator cuff tears enlarge? In 2015, 2 authors looked at this question and published a study that revealed that 11% of these partial thickness rotator cuff tears enlarged within 2 years. And in further trying to define the natural history, they found that 35% of partial thickness rotator cuff tears enlarged within 5 years. In 2018, another study was published evaluating the same clinical question, and what they found was that rotator cuff tears that were less than 50% of the overall width enlarged 14% of the time, but if the rotator cuff tear was greater than 50% of the width, those tears enlarged 55% of the time. What if the tear is symptomatic? Well, that question's been evaluated. As recently as 2017, there was a publication that looked at tear progression of symptomatic full thickness and partial thickness rotator cuff tears. What they found was that 26% of symptomatic partial thickness tears enlarged within about a year and a half. So what are the treatment options for partial thickness rotator cuff tears? We do know that physical therapy is a clear option. Physical therapy even works for full thickness rotator cuff tears. In Journal of Shoulder and Elbow Surgery in 2013, the Moon Study Group published a very large study looking at the results from physical therapy for patients who had full thickness tears and found that they often did just as well as patients that had surgical repair. The biggest difference in the 2 study groups was that patients with an intact or healed repaired tendon were stronger than those who did not have surgical repair. The most common injection option in orthopedics today for this problem is still the subacromial steroid injection. We do have some data on the outcomes of subacromial steroid injections for this problem. In 2009, there was a nice study published that showed that the average duration of pain relief from a single subacromial steroid shot was less than 6 weeks in about 27% of the patients, 6 weeks to 6 months in 37% of the patients, and greater than 6 months in only 36% of the patients. Now, there are some downsides to steroid injections that have been well characterized in the literature. We know that steroid shots, especially repetitive ones, can damage collagen structure, they can reduce collagen density, they can reduce tenocyte migration. Steroid shots can reduce fibroblast proliferation, they can soften rotator cuff tendon, and we know that they can lead to increased surgical infections when any surgery is done near the site of a steroid injection within a year. It is because of the many catabolic side effects of steroid injections that many doctors are looking for other injection options. Platelet-rich plasma has been a frequently looked at injection option to replace steroid injections for this problem. In 2016, there was a level 2 randomized study looking at 40 patients evaluating platelet-rich plasma injections versus steroid. What the authors concluded was that PRP gave better symptom relief than steroid at 3 months, but that the results were equal at 6 months post-injection. One of the criticisms of this study is that the platelet-rich plasma was not quantified, so we do not know the platelet dose or the other quantification numbers associated with the treatment. In 2018, there was another level 1 study looking at sodium hyaluronate versus PRP for partial thickness rotator cuff tears. In this protocol, patients got weekly injections 4 times, and then they were followed for 12 months. What the authors concluded was that the PRP plus sodium hyaluronate group did better clinically than the PRP group, which did better clinically than the other 2 remaining groups. They did attempt to quantify their PRP, and in this study they drew 20 cc's of blood, they used a 2-spin system, and they injected 4 cc's of what was noted to be 3 to 4x PRP. However, we do not have the data to know the actual platelet dose in this study. It is nice to note that they saw a benefit of PRP even with what is likely to be a low overall platelet dose compared to what many clinicians are doing now with 60 cc blood draws and 5 to 6x PRP. In 2019, a meta-analysis was published looking at 5 separately published PRP studies for this problem. The authors concluded that PRP injections may not be beneficial in the short term, but they readily admit that interpretation of the literature in this meta-analysis is essentially not possible because there's no reporting on the cytology or quantification of the PRP. In 2020, some Canadian authors did a nice level 1 study with 99 patients in the evaluation. PRP was compared to steroid for this problem, and the follow-up was 3 months. What the authors noted was that the PRP injected patients did better in terms of pain at 3 months, but not at 6 weeks. However, when you look at the PRP system that was used, it was the RegenLab system, which is a 10 cc blood draw from which 5.5 cc's of PRP is injected. And so this is essentially 1.6x leukocyte poor PRP that is used. So in my opinion, this is most likely relatively low dose of platelets and platelet-derived growth factors. We have to compare this to a 60 cc blood draw where the same 5 cc's of PRP is made at a much higher concentration at a much higher platelet dose. Just this year, there's been yet another study published looking at platelet-rich plasma injections for partial thickness rotator cuff tears. This is a level 2 study. They have nice imaging with a 3 Tesla MRI scan showing no significant rotator cuff tearing. So this is primarily a tendinopathy study. All of these patients had 1 prior steroid shot greater than 6 months before PRP. All of the patients enrolled in the study had had at least 3 months of therapy before PRP. So this is truly refractory symptomatic rotator cuff tendinopathy. The authors quantify the PRP nicely, and they quantify it to be a leukocyte-rich PRP. They use a 2-spin system. They draw 30 cc's of blood, and when you look at the quantification numbers, they are essentially delivering about 5 billion platelets per PRP injection with a WBC count on average of 11.2. So now we're getting closer to what I think is the more typical platelet doses when we're drawing 60 cc's of blood and injecting 3 to 6 cc's of PRP. What these authors found was 94% of their patients showed pain, American shoulder and elbow score, and constant score improvements by 6 months. 84% of the patients returned to sports at the same level at an average of 2.8 months after injection. Only 7% of their patients required a second injection. So here we have a recently done good study with PRP quantification showing that at a higher dose of platelets that patients can do very, very well from a single injection and get back to sports and other activities. Let's talk about some of the other orthobiologic options. I'd like to talk briefly about micro or nano fat because these are the 2 FDA compliant ways to use fat in the United States right now. In 2018, a level 3 study was published. It's relatively small with 18 patients. This was based on the lipogems technique. The adipose patients had better ASES scores at 6 months and 1 year with a 50% reduction in pain at 1 year. There's no imaging results post-procedure, but this is a nice level 3 pilot type study. In 2020, a level 1 pilot study was done with N equal 15. This was the transpose slash matrace system, and the adipose patients had better American shoulder and elbow scores at 6 months and 1 year. So we do have 2 published pilot study results showing that adipose, whether the micro or nano fat versions, may be helpful for symptomatic partial thickness rotator cuff tears. What about the allograft options? And so I'm talking now about amniotic fluid, Wharton's jelly, exosomes, and umbilical cord blood or tissue. These are things that, as we all know, are being widely marketed for this problem. However, there's a almost complete lack of data. When you look at these products and try and critically evaluate the evidence, you'll find that we have no significant human outcome studies using any of these products for this diagnosis, and we have significant FDA documentation that they are not appropriately registered with the FDA for this diagnosis. There is one product that has done a pilot study. This is a product called Clerics Flow. It's from Amniox Medical. It's an injectable umbilical cord / amniotic particulate product. In 2019, the authors noted here looked at 10 patients with 6 months follow-up, and from a single injection of this Clerics Flow, they noted improvement in range of motion and in pain, but obviously with only 10 patients in the case report, these are not statistically significant numbers, and there was no comparison group. One of the things that we note as clinicians in the marketing for these types of products is a lot of times these products will talk about being better than steroid or being better than platelet-rich plasma. Here's an example from this company's documentation that there's unclear benefits of PRP despite many level 2 and even level 1 studies on this exact problem. And we've only got one published study on this product. So I'm not sure how we can throw stones at the unclear benefits of PRP when we only have one published case study of 10 patients for this product. There's a little bit of a mismatch here. Bone marrow and bone marrow concentrate are 2 additional orthobiologics that have been studied for this problem. I haven't been able to find any significant literature on using bone marrow alone for symptomatic partial thickness rotator cuff tears. That would be something like the Marrow Solutions device, but there's just simply nothing published on human outcomes yet. There is some data published on bone marrow concentrate, although it's sparse. In 2018, these South Korean authors published a comparison paper looking at one group that got physical therapy and the second group that got a combination of bone marrow concentrate and PRP. There were 12 patients in each group. They used the Biomet system not only for the BMC but also for the PRP. And what we note in their technique is that they injected 2 cc's of BMC along with 1 cc of PRP, and they followed these patients up for 3 months. What they noted was that the patients that had the BMC and PRP had better pain scores and American shoulder and elbow scores, and that these results were only significant at the 3-month mark and not at the 3-week mark. There's really only been one other published study in the literature looking at bone marrow concentrate for partial thickness rotator cuff tears, and that was published in 2020 by Chris Centino and some of his colleagues. In his study, they looked at 14 patients that received an injection and 11 patients that received therapy. It is really important to note that 10 out of the 11 patients did cross over to receive an injection. One of the nice things in the study is they did identify the composition of the injectate. It was not a pure BMC injectate. They used 1 to 2 cc's, and in that, we'll call it 2 cc's, 60% of it was BMC, 20% of it was PRP, and 20% was platelet lysate. So this was a combo injectate, if you will. They did follow these patients for a year, and they noted that the DASH scores, which is a shoulder outcome measure, were better up to 1 year post-injection. So there really haven't been any pure bone marrow concentrate studies published in the literature, which is one of the reasons why we did our study. Of course, if none of these injection options work, there is a surgical option. So here's an example of what happens when you do an arthroscopic tendon repair for these problems. This is a 2009 study published in JBJS. 41 patients all had their partial thickness tears converted to full thickness tears. And the results at a year showed a 93% patient satisfaction, and 88% of the repairs were intact at 11 months. In 2018, a study was published, which I like because although this was a study on complete tears, there is a biologic component to this rotator cuff repair study. What these authors did was at the end of the repair, they made little vents in the bone marrow using a 2mm punch and making 2 or 3 holes into the greater tuberosity in order to open up the marrow space. You can see on the video there that little punch going into the bone. That releases or allows some of the marrow elements to release, whether it's stem cells, growth factors, cytokines, and other proteins. And that was shown to significantly improve the surgical outcome. 52 patients were treated. 91% of the patients had intact rotator cuff repairs at 2 years by MRI. And the authors noted that patients with healed rotator cuff tendons did much better than patients without healed rotator cuff tendons. So this was a nice surgical study showing that just by taking that little punch right there, you can access the bone marrow space and get some biology involved in the healing process for free. So let's talk about our study. We had 2 primary study questions. The first one is, what is the cellular analysis of our in-office, single-site, multi-depth, ultrasound-guided posterior iliac crest bone marrow aspiration? We were just curious to see if our in-office technique was matching published data. The second clinical question is, what is the outcome from a single ultrasound-guided injection of bone marrow concentrate for rotator cuff partial tears? And so here are some of the highlights from our study design. This was a prospective study with 25 patients. All patients had MRI or ultrasound imaging prior to inclusion in the study. The average range of tears was from 15% to 85% of the width of the rotator cuff. The aspiration protocol was such that all of these were done in the office. The patients were placed in the prone position. Ultrasound was used to identify the iliac crest. These aspirations were done under local anesthesia only. This was a single cortical site with multiple depths using a readily available multi-port Jamshidi needle. Our BMC protocol was provided by Selling Biosciences. We used their ART BMC device. This is a nice device that allows collection of 55 to 60 cc's of bone marrow aspirate. It is a single spin of approximately 15 minutes and results in a 6 cc bone marrow concentrate output. We did cellular analysis on all of the bone marrow concentrate, and 15 of the patients had matched bone marrow aspirate cellular analysis done as well. MRI imaging was done at 6 months and 1 year post-injection. The patients reported NPS scores, SANE scores, and American shoulder and elbow scores. The cost to the patient for inclusion in the study was $0. As the treating doctor, I received no grants or honorariums or stipends. We did have a PhD dream team to ensure that our cellular analysis was done properly and that our results were analyzed using appropriate statistics. And this is showing our Upika protocol. Upika stands for ultrasound-guided posterior iliac crest aspiration. You can see in the video on the left, the patient is awake in the prone position. Sterile technique is observed. In the CT scan to the right, you can see that with the patient in the prone position, the posterior iliac crest is reproducibly wide with a large safety margin. You can compare this to the anterior iliac crest, where the inner and outer tables are much more variable in anatomy with a much smaller safety margin. The needle that we used was an 11-gauge multi-port Jamshidi needle. They're available for around $20. The rest of our protocol includes using 10 cc syringes because we believe that we can get a higher stem cell aspiration volume by using the smaller syringes. We placed 1 cc of heparin flush into each syringe, which resulted in about 2,000 units of heparin being in each 7 to 8 cc's of bone marrow aspirate. Our technique doesn't require a drill. It doesn't require a mallet. It is a superficial to deep technique, again, in the interest of safety. I do 2 aspirations at each level, which results in about 15 cc's of bone marrow aspirate being obtained at each level. Each successively deeper level is 5 millimeters deeper. And what you can see from the CT scan, once again on the left, is we have about 3.5 to 4.5 centimeters of depth in the normal human pelvis before we run out of any safety margin. A more in-detailed look at our protocol can be found at the website listed below. Our complications were non-existent. We had no infections, no fractures, and no neurovascular injuries. Our cellular analysis was done with the help of the PhD team at Selling Biosciences. We noted that our CFU per cc in bone marrow aspirate was 870. We could have stopped there, but because we know that centrifuging can raise the concentration even further, we did centrifuge, and we noted that we had a 6-fold increase in our CFUF per cc by centrifuging, which resulted in a CFUF per cc in our bone marrow concentrate of 4,907, which is actually well above most published CFUFs per cc in bone marrow concentrate. Obviously, you can't compare these results across labs on different days or different locations, but it was a nice confirming piece of data that showed that our technique can put us in the ballpark. This is an example of the ultrasound guidance that we used. We ended up with 6 cc's of total BMC injectate. We typically injected 1 to 3 cc's intratendinous, whatever the partially torn tendon would hold, and the remainder was injected into the subacromial space. Our results: the last patient was treated in August 2018, so 2 years after that we had a little bit of a party because it was time to crunch the numbers. We had 15 patients with matched BMA and BMC cellular analysis. Our average age was 53 years, and the tear size ranges were 15 to 85%. In terms of pain, our patients entered the study with an average of 6.3 on the pain score. By 3 months after the injection, that pain score dropped down almost in half to 3.7. And if we go all the way out to 2 years, we can see that the results were durable out to 2 years with pain scores of only 1.8 from a starting point of 6.3. Our SANE scores showed a similar trend. 3 months after the injection, patients had a 61% SANE score. By 6 months, patients reported that they were 74% better. And even at the 2-year mark from this single injection, the SANE scores were at 84% better than prior to the procedure. Our American shoulder and elbow score results had similar improvements that were durable out to 2 years. The average ASES score prior to the procedure was 50. We had a 50% improvement by the 6-month mark. And if you look here, from a single injection, we maintained functional improvement for these patients at a level of 80 on the ASES score all the way out to 2 years. So that's like a 60% functional improvement was maintained through 2 years from a single injection. I think that's a significant treatment option at this point. Our imaging was equivocal at best. Most of our post-procedure imaging showed no significant structural improvement in the partial tear, but another way of saying the same thing is that most of our imaging post-procedure did not show significant worsening of the tear either. So in conclusion, the Upika technique is a safe in-office bone marrow aspiration technique that yields a CFU per cc that is on par or better than other published techniques. About 50% of our patients had 50% reduction in pain by 3 months. Our patients averaged an 86% SANE score at 1 year, and we're still at 84% better at 2 years post-injection, and our ASES functional score results were very similar. Only 16% of our patients went on to surgery within 2 years. That translates into 4 out of the 25 patients went on to surgery within 2 years. So do I think BMC is a reasonable alternative as a treatment option for symptomatic partial thickness rotator cuff tears? Absolutely. I thank you for your attention, and I am happy to continue the dialogue at any of our social media outlets that you can see on the slide here. Thank you once again to the organizers of this meeting for the invitation to present this information.